Hi, everybody. Thank you for coming. We have Dr. Wall here from the Department of Anesthesiology. I'm going to let him introduce himself, and you guys can enter your questions in the chat or unmute yourselves either way.
Yeah, hi. Glad we're able to do this. Sorry it wasn't in person, but we have to be flexible. So yeah, my name is Mike Wall. I am the chair of the Department of Anesthesiology at the University of Minnesota. I am a cardiac anesthesiologist and intensivist that works in the cardiothoracic ICU and the surgical ICU at the University Hospital. I've been doing cardiac anesthesia and critical care for about 27 years now. Still love going to work every day, and it's a great practice.
I can start with one. What made you choose anesthesiology, and why have you stuck with it for so long?
So pretty much once you pick a specialty, most people don't change because you have to go back and redo a residency. I picked the anesthesia because I really liked pharmacology and physiology in medical school. During medical school, I was exposed to critical care as well, and that's the part of medicine that I really liked. I had great mentors and advisors who were anesthesiologists, and that's how I picked it. So anesthesia is basically applied physiology, and it's applied pharmacology that we basically practice every day. So it's very cool. How does my day usually go? What do you want to know about my day?
Kind of like just your routine and stuff. Like, what do you do before surgery? What kind of goes on during surgery and stuff like that?
You know, I'll take you through a day in the cardiac operating room. So typically, I will be working with an anesthesia resident and often an anesthesia fellow. And the three of us will help take care of the patient. We typically meet the patient in the pre-op area around 6:15, 6:30 in the morning. We say hi to them. We get their IV started. We then take them back to the operating room, usually around 7. We connect them to all of our physiologic monitors. We then give them some medicine to have them become unconscious. Once they're unconscious, we put in a breathing tube and put them on a mechanical ventilator that breathes for them. We turn on some anesthetic gases to make sure they don't remember anything. Then we put in a pretty big IV and a big vein on the right side of their neck, so we can measure their heart function during and after surgery. We put in an echo ultrasound probe in their stomach, so we can actually look at the heart during and after surgery. Then the cardiac surgeons will prepare the patient for going on bypass, which is a heart-lung machine. They go on bypass. We can then stop the heart so the surgeons can fix whatever they need to fix on the heart. After the heart's been fixed, we basically let the heart start beating again. And then we come off the heart-lung machine and their own heart and lungs take over for the machine. We then fix any abnormalities in bleeding or clotting or their electrolytes and all that kind of stuff. Surgery finishes, we then will take the breathing tube out at the end of the case and take the patient to the ICU. And depending on the case, we can show up in the ICU between, I would say the earliest we'd get up there is noon. Probably a more complicated case might be 2, 3, or 4 in the afternoon. And that's a normal day in the operating room. The nurse anesthetists are advanced practice nurses. The CRNA stands for Certified Nurse Anesthetist. So they are advanced practice nurses. We basically work as an anesthesia care team. There are not enough anesthesiologists in the United States or in the world for us to actually be sitting in every room for every case. So we will often work with 2 or 3 nurse anesthetists who are covering 2 or 3 different cases. We do have some nurse anesthetists that do cardiac anesthesia. You know, so we work with them as part of, it's called an anesthesia care team. So physicians, we go to 4 years of medical school. Well, we go to 4 years of college, 4 years of medical school, a year of internship, 3 years of residency, and to do cardiac anesthesia, another year of fellowship. Whereas nurses go to nursing school and do 3 years of practical CRNA training. So the training is completely different. Nurses are nurses, doctors are doctors. The duration of training is different. So they're not the same. I think, you know, good anesthesiologists need to be calm in a crisis. Anesthesia is often referred to in similar ways as pilots and airplanes. You know, most of the time things go real well, and the flying is very smooth. But when things go bad, they go bad in a hurry, and you need to be able to calmly get yourself out of whatever problems you have them in. So that's what I think makes a good anesthesiologist. You have to be calm in a crisis and a good communicator.
Hi, Dr. Well, I have a question.
Yeah.
Can you talk about continuity of care in anesthesiology? I'm interested in a field where I can build long relationships with patients, but I have heard that anesthesiology is not like that.
Well, so it depends. So anesthesiology is not just the specialty of, you know, taking care of patients in the operating room. So within anesthesia, you can actually subspecialize in a variety of things, such as I also do critical care. So I cover patients in the intensive care unit, usually for a week at a time, which is how long we usually cover the ICU. We have people who can subspecialize in pain medicine, and that's chronic pain management. So they'll have patients that they follow for years with their chronic pain problems. You can actually specialize in sleep medicine or palliative care, so end of life care. So, you know, the nice thing about anesthesia is there's all different types of anesthesia specialties. So if somebody really does not like clinic and really wants to have a very intense, acute patient exposure, you can do that. And then at the other end of the spectrum, if you want to deal with a real chronic problem like chronic debilitating pain, you can do that. If you're interested in end of life and palliative care issues, you can do that. So I think, or somebody like me who likes critical care. So I think that's the cool thing about our specialty, is we deal with people from newborns to 90-year-olds, and we deal with every type of surgery or every type of case, from an outpatient healthy knee arthroscopy to heart and lung transplants, which is the stuff I do. Yeah, I think we all have memorable patient experiences. The one that's pretty cool just happened is as an ICU doctor, I've been working a lot during the COVID pandemic, and I was watching the news the other day, and they had a story about an mHealth Fairview patient who had COVID and was sick for a long time. And they showed him, back at home, kind of doing his thing. And I helped take care of that patient. So that was, yeah, I heard his name. It's like, I know that name. And, he won't remember me because he was in a coma the whole time I was taking care of him. But I remember him. So that was pretty cool.
Could you elaborate more on how your daily life or work life has kind of changed with the COVID pandemic?
Well, I mean, I think for the ICU part of my job, our system, our healthcare system, ended up opening a whole hospital for COVID patients. We opened Bethesda Hospital, which was a rehab hospital that was going to be closed. And when the pandemic hit, our leaders thought, we have this building that actually had critical care capability and had regular hospital bed capability. So it was amazing how they converted that hospital, which was going to be closed, basically into a COVID hospital. So all patients in our 10 hospital system, the Fairview mHealth system, basically were sent there. So we were able to cohort patients at Bethesda, and then patients who we thought were really sick, who might need to go on temporary temporary lung support called ECMO, extracorporeal membrane oxygenation. Those patients actually got sent to the U with COVID. So that changed. Of course, early on in COVID, we didn't really know what it was or what we were dealing with or how bad it would be. We had to shut down the hospital essentially for elective surgery for a little while we figured out how to deal with it. We went through the whole shortage of personal protective equipment shortages and testing shortages and all that stuff. Now, knock on wood, we see a light at the end of the tunnel. Hospital operations are essentially back to normal. Our medical students are back to, taking care of patients. We're still testing patients for COVID, and, the herd immunity thing hasn't happened yet, but it's been a very interesting ride. Does that answer your question about the COVID thing?
Yeah, thank you.
So balance mental health and life balance. So I don't really like the term work-life balance because that implies that there has to be 50-50 all the time, which is impossible. So I tend to like work-life harmony. And you know, can it be done? Absolutely. And you know, I think you have to have your priorities right. And I can just say that throughout, you know, my career, I've been fortunate. I have two grown kids who, when they were little, they were both into all kinds of sports. They ended up being swimmers, and I went to most, if not all, of their meets. When they swam in high school, I made it to all their meets there, and eventually both of them swam all 4 years in college, and one was swimming in California, the other was swimming in New England. So we couldn't go to all their meets. My wife did, but you know, I went to at least one or two every year and got to their championships. So I think you can do it. You just need to plan ahead, and you know, organize your time, and also do stuff you like to do. Personally, I like to play golf. So you know, that's my escape outside, you know, 4 hours. I even like to play in the rain because it's quiet and there's nobody else there. But I think you got to find something you like to do outside of work. But the important thing, I think, is to find work you really like to do. And I've really never thought of what I do as work because it's fun.
About how long did your residency take? And do you have like any memorable experience from that?
So all residencies are slightly different lengths, but they're set up front. So anesthesia is 1 year of internship and then 3 years of anesthesia residency. And then if you want to do a fellowship in something, those different specialties that I mentioned, in anesthesia, all the fellowship programs are 1 year long. So I did two. I did one in cardiac and one in critical care. So I was an intern for a year, I was a resident for 3, and I was a fellow for 2. So it took me six years to train. You know, other specialties have different durations of training. So and they're changing. So when I was a resident, for example, general surgery was a year of internship and 4 of residency, then followed by, you know, 2 to 3 years of fellowship training. What general surgery's done is they've kind of combined and shortened that 8 years into 5 or 6 or 7 year continuum. So depending on what field you go into, that determines how long your training is. You know, so that's kind of how that deal goes. You know, there's lots of stories that you know, my friends and I still talk about when I was a resident. I'll tell you one. I was an intern. I was on the cardiac surgical rotation. I was a resident in Seattle. And it was really early in the morning, and we heard a code blue, a cardiac arrest, outside of the lobby at the university hospital. It's like, that's interesting. So we went because it was early in the morning, and we thought, well, we'd probably get there a little before the paramedics. Anyway, we get there, and we're looking at this patient, and my friend and I was like, that guy looks really familiar. Well, it turns out he was a patient that came into the hospital the night before and was supposed to have surgery that day, and went outside to have a cigarette and had a cardiac arrest before his surgery. So we actually rushed him downstairs, and he got put on bypass kind of emergently, and he eventually lived and walked out of the hospital, but I do remember that one. That was a classic. So what medical field are you thinking of?
I was thinking of just overall like getting into med school is getting more difficult, like how to sustain the 4 years of medical school residency and everything after.
Well, I think, yeah, getting into medical school has always been tough. And, it still is. I think, medicine is, it's fun, it's interesting, it's changing, for people who like dealing with people and like science and technology. It's a great, great career because there's never a dull moment. But as far as, how to be successful, I mean, I think, basically what I tell incoming residents when they ask this question, what do you need to do to be a good, anesthesia resident at the University of Minnesota? I basically tell them, I said, look, and I'll tell you guys this, you all did something really well in high school, or you wouldn't have gotten to where you are in college. You're probably all doing cool stuff in college, which if you get into medical school will help you get into medical school. When you're in a medical school, you're probably gonna, be good students, and you might find one or two other things you like to do, outside of school. So you're successful there. So basically, people who end up in medicine, typically are people that, get things done, that are self-motivated, and are successful. I think the key to be successful in medicine, and this is true with anything, you have to find something that you really like doing. And that's kind of the cool thing about medical school is you have, basically about 2.5, 3 years to kind of see what different specialties are out there and, what things you like to do. And, there's a huge variety of things one can do after medical school. And then the other thing is, I don't know how many of you changed your major, but, there's a lot of people that start in one thing, and they do it for a year or two, and then they realize, oh, I want to do something else. And that's okay. People do that all the time. Because you don't really know what something's going to be like until you're actually doing it every day. So I think that's the thing to be successful. Just keep doing what you're doing. If you say you're going to do something, do it. And then when you're looking for that thing, in medicine, that you want to try to find something you really like. So my job has changed a lot over time. So I've always done cardiac anesthesia, mostly in critical care. My first job when I finished all my training was actually in the Air Force. And I was stationed in San Antonio, Texas. And, we were an academic medical center just like this one. We had an Air Force residency program. We had fellows in critical care. And so I was doing essentially the same type of thing I do now. The only difference was I was on active duty in the Air Force. I was on active duty between Persian Gulf 1 and Persian Gulf 2, so that was a long time ago. And during that time, we developed a thing called a critical care team and a mobile field surgical team to basically evacuate critically ill patients over the Atlantic or Pacific to get more specialized care. And that was really fun because no one had done it before. We were doing it, and it's the type of thing you could only do in the military. When I got out of the Air Force, I ended up at Wake Forest. My job there was, again, cardiac anesthesia and critical care, but I was also in charge of developing an entire curriculum on echocardiography and ultrasound. And, so I did that. I was also working in a lab. We were looking at gender differences in drug response that we use after cardiac anesthesia and we use in the ICU. And then moved to UT Southwestern in Dallas, where basically I started up a critical care program at the Dallas VA, and we started a fellowship in critical care and cardiac anesthesia at UT Southwestern, which was great. And then I moved to Washington University in St. Louis, where I still did cardiac anesthesia and critical care, but there I was responsible for running about 120 operating rooms every day. All that went along with that. And then most recently, 7 years ago, I got here, almost 8 now, where I'm the department chair. Now what I do is I still do cardiac anesthesia and critical care, but not as much as I used to. And I spend more time doing administrative stuff, working on stuff for the system, and helping our 70 faculty advance their careers, working with our 40 residents and 10 fellows on the stuff that they want to do. So my job has changed over time as I've done different things.
Do you currently do like any research or have like any future research projects?
So I don't. I help people hook those things up. And if you're interested in research in anesthesiology, send me an email when you're done. We currently have a research coordinator, 5 research assistants, a biostatistician, a medical editor, and I think right now we've got 30. We have 20. I'm just looking. We have 23 clinical trials ongoing right now where we're actively enrolling patients. We also have a very busy basic science lab where we are doing research in pain mechanisms with 2 of our basic scientists. So in our department, we've got a lot going on.
Hi, Dr. Well. I have another question.
Yeah.
How do you deal with the loss of patients and the emotional toll on your mental health? And how do you break bad news to your patients' families? Like, do you learn that in medical school and stuff?
I'll do the, let's see. So the first one is, how do I deal with it personally? So that's not fun. I think, I was a college athlete too, and I don't like to lose. But I think, when you're dealing with patients as sick as the ones that I deal with, you just have to be confident that, you and your team has done everything possible for that particular patient. And, there's only a couple things true in life, and that's death and taxes. And eventually everybody dies. We can't stop that. So all we can do is do all we can to try to get somebody through a critical illness. And, sometimes it doesn't work. And I think that was the thing that was so hard on a lot of the ICU physicians during COVID, because normally, at least in cardiac surgery, I'll go a week and nobody dies. In a COVID unit, people were dying, not quite every day, but 2 or 3 times a week. So it was much different. But again, there's only so much you can do, and if you're confident in you and your team, then that's how you get along with it. How do I break bad news to patients? So what I typically do now is now this has been hard too, but normally in the intensive care unit, we make rounds a couple times a day. So once in the morning, once in the afternoon. Morning rounds are, to figure out what happened last night, make our plan for what we're going to do during the day, and give that plan to the nurses who essentially carry it out. And then afternoon rounds are, okay, what happened during the day? What happened with our plan? How are we going to get this patient tucked in, at night? What stuff do we need to do overnight? So now it's really, COVID screwed all this up, but now what's really cool is we actually make rounds with the family. So the family is standing outside the patient's room, or sometimes we actually make rounds in the room. We'll use, unfortunately, all of our medical jargon, and then we'll translate at the end for the patient's family on what that all meant. So basically the families are kind of brought along, every day throughout the day. And then what I typically do is anybody who's been in the intensive care unit for more than a week, we have a family meeting, which basically it's whoever they want to bring, and whatever teams are working with that patient. So for example, if it's a patient who, let's say, had a liver transplant, it would be the liver transplant docs, it would be the ICU team. Let's say the patient has some kidney problems, so it might be the kidney doctors. And we'd all sit around with the family and just have a discussion on what's going on. We don't really formally get taught that in medical school. I know I wasn't, but we learned by watching other people do it. If you're in the ICU, let's say you're in the cardiac ICU here, I'm going to be there for a week, and then you'll be working with 3 other faculty members, and I'm sure all of us deal with these problems a little differently. And then you can basically see which things you like from the 4 or 5 different people that you see. And of course, you'll do, when you're all said and done, you'll do 6 months of critical care as an anesthesia resident. So you'll have 6 times 4 exposure to different attendings. And so basically you kind of learn by seeing people. And then, often what I'll do is, if I have a senior resident in the unit, I'll let them run the family meeting. If we have a fellow, the fellow will run the family meeting. So that's how you learn how to do this stuff, by watching other people do it and then doing it yourself with somebody helping. Yeah, so that's not fun, actually. So there is this. So this is an interesting little problem in anesthesia. So that's called awareness. We don't want people to be aware of what's going on during an anesthetic for obvious reasons. We also use medicines that paralyze people. So the last thing you want to do is be awake but paralyzed and not able to move. And experiencing pain. So these are bad things. So we have monitors literally for everything. We can monitor, your heart. We monitor your lungs, the pressure in your lungs, the oxygen going in and out, the carbon dioxide going in and out, all your laboratory stuff. We can monitor your heart function continuously. We can look at your brain waves during surgery. But what we do not have, believe it or not, in 2020 is a monitor that would tell us, is this patient awake or is this patient asleep? We have some stuff that gets us close, but we don't have a monitor that does that. So in certain cases, anesthetics, there's a higher risk of awareness than others. And those happen to be severe trauma, where your blood pressure is really low, because of all our drugs also lower your blood pressure, cardiac surgery, which is what I do, and obstetric anesthesia. which is another area where often there's emergency cases and often there's other things going on. I've only had one patient, knock on wood, have awareness for me. It was back when I was a resident. It was a young, otherwise healthy patient who had received several gunshot wounds to the chest. And basically, this guy had no blood pressure. He was essentially dead. And we put in IVs in his groin, and we thought they were in veins, but it turns out one of them was in an artery. And we actually got the way we figured that out is the pressure on that vein started to go up. And then we realized we had an arterial line, which is fine. But this particular young man, once we got a blood pressure back, we were able to turn on some more anesthetics, and the surgeons went ahead and fixed all the holes. And he did remember some of that operation. We basically told him, it's like, well, you had no blood pressure for a while, so it's probably better than being dead, having remembered a little bit of what happened. But it's a serious problem that actually can lead to post-traumatic stress disorder, because if you think about it, there'd be nothing more horrible than being awake, paralyzed, so you can't move, because of a drug we've given. You can't talk because there's a breathing tube in your mouth. So there's no way you can tell us that you're aware. And then to make it worse, having pain. Fortunately, this patient, we'd given a bunch of narcotics. So this guy didn't have any pain. He just remembered being awake. But that would be even worse, having pain. So basically, when that does happen, and it does, it's very, very uncommon, but it can happen. What we do now is we realize that it can lead to post-traumatic stress problems, and we rapidly hook them up with a psychiatrist because the patients think somehow it's their fault, that they remember. Of course, it isn't. Anyway, that's what we do now. We offer early counseling and encourage people to do it. So it does happen still.
You talked about doing your residency in Seattle and working in a lot of other areas. What made you kind of settle in Minnesota?
The weather, right? No, so seriously, my boss, when I was in St. Louis, basically told me one day, he said, Mike, have you ever thought about being a department chair? And I told him, no, not really. And he said, no, I think you should think about it because I think you'd be good at it. And what that was it was a way for him to give me a lot more work to do and not pay me anything to do it. But after about 3 years of that, he said, I think we should start looking for opportunities for you to go be a chair somewhere. Turns out both of his kids went to McAllister, and he loved the Twin Cities, and he knew people here at the University of Minnesota, and a job opened up here. He said, this is a good opportunity. You should go look at this place. And I did, and here I am. So we love it here.
Hi, I had a question.
Yeah.
Can you maybe talk about some of the adverse effects that come with anesthesiology? Maybe if the patient doesn't know that they're allergic, or how you handle those situations?
You mean the drugs and stuff?
Yes.
So, yeah, so so allergy is a problem that we worry about. We actually worry about a more severe form of allergy called anaphylaxis, which basically leads to a really low blood pressure and difficulty breathing. And that's most commonly encountered with antibiotics. So you might have heard of penicillin allergies. So that would be the most common allergy type problem we have with anesthesia. If it's a mild allergy that doesn't lower the blood pressure, doesn't do anything to the lungs, just causes a rash and some itching, we can use some medicines called histamine blockers, which you can, buy over the counter. We use IV ones. But if it's a more severe reaction, sometimes we actually have to use epinephrine to treat that and stabilize it while your body kind of gets over the allergy problem. So, people can be allergic to all kinds of stuff. Antibiotics are the most common. Those muscle relaxants I was telling you about, you can have allergies to that. Actual allergies to local anesthetics is not that common. People think they have them, but it's usually not an allergy. So those are the most common allergies. The other disease that some of our drugs can cause is a disease called malignant hyperthermia. And that's it's a very weird disease that's caused by one of our muscle relaxants called succinylcholine, and can be caused by all of our inhaled anesthetics. And basically what it does in people who are prone to have it is it causes a massive dysregulation of calcium metabolism, and patients get really, really stiff and rigid, and they get really hot. And if not treated, they can die. Thank God I've never seen it. It's very rare. It's treated with a drug called dantrolene, which all of us, know how to give and where it is and all this other stuff. It's a genetic disease. So, if patients have a family history of a patient that had a sudden death in the operating room with some of these other signs and symptoms, we can use anesthetics that don't have those drugs in them. We can also do tests. There's some genetic tests which are okay. They're not perfect. And there's also a test called a halothine or caffeine contraction test, where we actually have to take a piece of somebody's muscle and expose it to the triggering agents to see if it triggers. But those are those are kind of the worst things for anesthesia. We tell everybody, if you're having an anesthetic, there's lots of complications that can happen with anesthesia and surgery. Little things, bruised lip, chipped teeth, awareness to horrible things up to and including death. So fortunately, those are very, very rare. Anesthesia now is very, very safe. But bad things can happen.
Okay, I think that was all. Thank you so much for coming and answering all our questions.
You're welcome. You're welcome. And if you guys, are interested in doing, clinical research or basic science research in our department,